we're going to move into the management of an inborn error of metabolism, and namely fatty acid oxidation disorders. I didn't put a map. I should. Looking at Oderic's map, I'm also based in Switzerland, and I'm calling you from Paris. And I guess after the Olympic Games, you all know where Paris is. So I'm going to skip that. So, as it states in the title, FAOD states for fatty oxidation disorders. It's a group of inborn error of metabolism that affects several genes encoding either transporters, either enzyme involved in the long chain beta oxidation. You see on the cartoon. So let me get the laser here. On the cartoon here, you have the key genes which are circled in red. The carnitine shuttle, CPT1, CPT2, and CACT, but also the key enzymes involved in the decarboxylation of the long-chain fatty acids, namely VLCAT, LCAT, LCCAT, which could be mutated, resulting in a partial or total loss of function, which will have a tremendous impact on the ability to process long-chain fat and to generate TCA cycle intermediates, and down the road, ATP production. You see in the small table here, I put the prevalence of these mutations. Those are the numbers for the United States, where newborn screenings are in place for quite some time now. So we have very accurate calculation here. And today we estimated within the project team that we have roughly 15,000 patients currently affected with long-chain fatty acid oxidation disorders. So it's considered a rare disease according to the FDA standards. So what's the clinical presentation of such disease or group of disease? Well, as you can imagine, if you're unable to process long-chain fat, which is a major fuel source, well, you may have major issues with respect to your development, where metabolic flexibility is a key requirement in tissues where you have a high energy demands. Obviously the brain, I'll start there, but it's also true for the heart, the muscle, the liver. And depending on which tissue you affect for this energy deficit, you have different consequences. For instance, in the liver, you're unable to process and metabolize and synthesize ketones, but you also have hypoglycemia, so hypoketotic hypoglycemia, leading to chronic liver dysfunction. In the heart, you have a kind of interesting cardiomyopathy phenotype, which is not heart failure with preserved ejection fraction, which is a kind of an unstable cardiomyopathy, which develop with time up to fibrosis. Certain mutations such as LCAT, which is LCAT deficiency, leads to retinopathy, likely due to the buildup of a precursor nasty metabolite, which is hydroxyacylcarnitine. I'll come to that later on when we'll talk about clinical studies. In the muscle, of course, all these patients are completely intolerant to exercise because they are unable to switch their metabolism and process fat into the mitochondria, and this leads to rhabdomyolysis with major muscle pain, elevation of CK levels up to 10,000 in certain cases, leading to ICU. So obviously, these patients have recurrent energy crisis events. First of all, hypoglycemia, which lead also to muscle failure and damage, and have also with age cardiomyopathy. Today, what's the current standard of care? Well, basically, these patients have to avoid long-chain fatty acids, and they rely mostly on medium-chain triglycerides, which are ketogenic precursors. They need to have frequently carbs, and they should avoid fasting episodes. And any type of metabolic stress, that could be fasting, could be exercise, could be a viral or immune challenge, could trigger a metabolic crisis. In case of a major metabolic decompensation, basically high-calorie carbohydrate could be administered as a drink, but usually it's within the ICU setting, and then it's an IV glucose treatment. One molecule, one drug was approved in the US in 2018 by FDA, which is called triptanoin, or named as Dojolvi as a commercial name, which is a pharma-grade medium-chain triglyceride using heptanoate or heptanoic acid as the backbone on the triglycerides. It is believed that obviously C7 are broken down into acetyl-CoA in the mitochondria, but since these are not chain, it's also replenishing the TCA cycle in intermediate and its so-called anaplerotic activity. In the late-stage clinical program that led to the Dojolvi approval, the team led by Jerry Vockley, mostly in the US, demonstrated that the product was able to reduce major clinical events, mostly driven by a complete reduction of hypoglycemic events and associated hospitalization. However, the impact on rhabdomyolysis or cardiomyopathy was considered as mild and non-clinically significant. So taken together, just to let you know, introduce to the concept that FAOD remains an unmet medical need for which I think we still need therapy to complete what Dojolvi is able to target. One reason to explain the lack of efficacy of Dojolvi on the periphery beyond the liver is that there's a very important first pass. So if you want these MCTs, when the hydrolysis took place and CSET is released in the portal system, goes to the liver, can make ketone. There's also free-floating C7, but 80% of the C7 is metabolized in the liver, suggesting that very little heptanoic acid is reaching the heart or the muscle for which there is a massive unmet medical need. So one interesting finding, and I think it's a major discovery, and this is extracted from a paper from Melanie Gillingham, long-lasting collaborator of us, is that these patients are unable to produce ketone. And here it's an experiment performed on 5 patients from Alaska, so native Indians there. And you see that in response to a meal on the left-hand side panel, you see that they all respond very well. They increase their free fatty acids, so they are able in the bloodstream to mobilize fatty acid from the adipose tissue. However, they are completely unable to process them and generate ketones. So normal fasting induced rise in lipolysis, but no rise in fasting inducing ketones. And as you know, and it has been well introduced by the first speaker, ketones are considered as a major alternative fuel source in certain tissues, such as the brain, the heart, and the kidney. Stephen has published on that topic using imaging technologies. And as you know, ketones are mostly produced in the liver. There's a small fraction of it that could be produced in the kidney, still under debate. These go into the bloodstream and is delivered in extrahepatic tissue where ketones could be terminally oxidized and generate acetyl-CoA, anti-CA cycle, intermediate and downstream ATP in the mitochondria. However, and this is really exciting, is that ketones play a role beyond energetics. And this was the work from the last 10 years, let's put it that way. And this was reviewed by Peter Crawford's lab in Nature Metabolism last year, showing that ketones play a major signaling role. And they even is a different signaling properties of acetoacetate versus BHB. And key pathways that are considered for today's talk are inflammation, targeting GPR109 or HCAR2, but also the inflammasome and NLRP3 that has been discovered by Dr. Dixit at Yale. Major impact on lipolysis with its inhibition with GPR109 HCAR2, but also playing a major role in redox homeostasis. Been shown that through different mechanisms that BHB induce a major remodeling at the epigenetic level, triggering the expression of the antioxidative defense system. So obviously, when we thought about the unmet medical need in FAOD, we thought that, well, if we could engage both the energetic component and also engaging the mechanistic signaling pathways that are engaged by ketones, well, we could maybe address this unmet medical need. And that led to the hypothesis here is that in FAOD, we might be in a position to bypass the genetic defects, delivering a high dose of DBHB in the bloodstream in the key tissues, such as the heart, the muscle as well, but also other tissues considered, including the brain, leading to acetyl-CoA production. So you really bypass the genetic defect, but also you may be able to reduce the production of toxic metabolites such as acylcarnitine by suppressing lipolysis, also being anti-inflammatory and also anti-fibrotic in certain key tissues. And that's what we try to demonstrate most recently using different approaches within the team. First of all, we wanted to substantiate the impact on energy deficit, and to do that, we started by generating cell line deficient for key genes in FAOD, and these are two cell lines depicted here. So obviously we have a wild type parental cell line in black here, and we generated a VLCAT deficient and an LCHAT deficient. So those are CRISPR editing, and they were verified by sequencing, and they are fully knockouts. Obviously, as you can see on the COS experiment on the left-hand side, so it's basically a respiration assay where you're able to measure oxygen consumption rate. And you see that basal respiration is really going down, as you would predict, in these two different cell lines, VLCAD and the LCHAT deficient. And if you put them under palmitate conditions, so palmitate will increase respiration as expected, but it's to a much lesser extent in both VLCAD and LCHAT. And if you bring DBHB in the equation, that's the right-hand side, this is concentration response experiments, you see that increasing concentration of DBHB delivered as a salt here in vitro is able to some extent to rescue maximal respiration in the VLCAD cell line here. But we completed that work for every cell line and all the genes that are affected in FAOD, suggesting that in vitro, DBHB supplementation restores mitochondrial respiration in a deficient cell. You could extend this finding, as I said, to all the genes affected by FAOD, VLCAD, LCHAT, CPT1, CPT2, CACT, as well as CCAT. And you can see here where I selected two doses, BHB 1 millimolar or BHB 3 millimolar, which is high ketosis levels. And we measured oxygen consumption rate. Every white bar is the normalized control 200%. And you see that whether you have a wild type cells or a knockout cells, the BHB to different extent could rescue the phenotype. What is interesting is depending on the severity of the phenotype, and I can tell you that these cells grow at different speed due to the major energy deficits they have, BHB, you need to reach more or less 1 to 3 millimolar. For certain cell line, we even saw the peak at lower level at 0.3 or 0.6 millimolar. So we had some interesting data in vitro suggesting that DBHB could serve as an alternate fuel source for these cells. At the same time, we had an interesting collaboration on what I said with Melanie Gillingham, which is one of the leading investigators in the space of FAOD, and she's based in Oregon at the OHSU. And there was a small study that was conducted, which was an acute efficacy study testing one of the product that was initially developed internally, which is a mix of DBHB salt, 10 gram, and it's a mix of calcium, magnesium, sodium salt. It's a bit flavored to improve the taste. And it basically, by one stick pack that you can see on the left-hand side here, provides 10 grams of DBHB that you respond as powder in a glass of water. And the placebo was here a maltodextrin beverage, which is matched for taste and calories, obviously, to make sure that we're really assessing the impact of ketone and not the impact of increasing calories only. So the idea was the following. So if we take adult patients with long-chain FAOD, they would have a mutation for one of these key genes in blue, CPT1, CPT2, LCCAD, LCHAD, VLCAD, or CRAT. And to diagnose them, we know that all these patients build up long-chain acylcarnitine, which are intermediate because they could not process long-chain acylcarnitine anymore. We know that exercise further exacerbates that phenotype, and it's been shown by Melanie's lab a while ago, and is well known also in the case of insulin resistance. And we know that acylcarnitine has really toxic metabolites. They promote insulin resistance, they are pro-inflammatory, they are pro-fibrotic, so they are linked to adverse clinical outcomes. So our hypothesis was, well, we think that DBHB supplementation acutely and before triggering that exercise period may reduce the buildup of long-chain acylcarnitine in the plasma in genetically confirmed patients. So, and that's what we did with the team in Oregon. And you could see it's a crossover study. We recruited 5 adult patients. I'll show you the characteristic in a minute. They were fully phenotyped, genetically confirmed. Acylcarnitine were also measured as a surrogate diagnosis. Basically, a patient arrived at the center the night before. Their food was standardized. You can't fast them, obviously, because they are really sensitive for fasting, and it triggers metabolic stress. We did a number of examination. There's a pre-beverage blood draw. Then they got the ketone salt or maltodextrin beverage. After 15 minutes, we get another blood draw and the catheter, and then they went for a treadmill program, which is a moderate exercise program. As I told you, they are really, really intolerant to exercise, so it's really to stress them, but not too much. And then they will have a 30-minute so they will exercise for 45 minutes or 30 minutes here, and then they will recover for 30 minutes, and we will have 2 additional blood draws. And then we'll measure also safety tolerability of the product using VASCOR and a battery of data. And we use here plasma acylcarnitine that were measured at the Mayo Clinic as a readout, as a pharmacodynamic biomarker. So those are the patients. You see, we have quite young patients. We have one 50-year-old still, 2 CPT2, 2 LCHAD, 1 VLCAD, genetically confirmed. So you have the mutation here depicted here by sequencing. You see they are on the higher end on the BMI. As I told you, they are relying a lot on carbohydrates, and you could see this on the adiposity. What I can tell you also is that the disease presentation is quite heterogeneous within these patients, and some patients didn't have any cardiomyopathy at baseline, if I can speak like that. Some did were on beta blocker and on ICD. Some patients were really compliant on MCT, some were not at all. So it's really an issue for this patient to stay or to avoid long chain fat in their daily diet. And these are the data. So remember, it's a single dose of BHB as a salt ahead of the exercise program, or placebo, which is maltodextrin, and it's a crossover. So everybody's his own control. In blue, it's BHB curve. In orange is maltodextrin. And on the left-hand side, those are the BHB concentrations. So kind of a pharmacokinetic readout, if you want. And you see clearly that if you administer BHB one single dose, you trigger nutritional ketosis reaching 0.4, 0.5 millimolar. If you put total ketone, you're closer to 0.6, 0.7 millimolar. And this is within the range or the ballpark numbers that we were expecting from healthy volunteers results. Obviously, as I told you, even they are on exercise, these patients are in orange, not able to produce further ketones. There's a bit of elevation, but you see to a very different extent compared to the DBHB treated patients. If we look at the biomarker we have been using for this proof of concept kind of study, measuring here C14 acylcarnitine, which is a clear biomarker for the diagnosis of long-chain fatty acid oxidation disorders, you see that, as expected, exercise increased the buildup of acylcarnitine levels in the patients, which was almost prevented by BHB supplementation, suggesting that the concentration that we were able to reach in this patient, we were able to suppress acylcarnitine buildup. This is true across all the species we looked at. Here I show you unsaturated long-chain fatty acid, acylcarnitine, C14-1, 16-1, C18-1. It's also true on the hydroxy ones, which are considered are the most toxic ones. And you see that across the board, even though the N or the numbers of patients is very small in that small pilot study, we do have pretty nice results and a clear PK-PD relationship in that study. And whatever the genotype, I did not, for the sake of time, show you the analysis by genotype, but we look specifically at the key biomarker in the LCHI, the hydroxy ones, and for the VLCAD, the C14 one, and they are very significantly reduced in response to BHB supplementation. Interestingly, you see that this effect is somehow specific. If we look at short chain acylcarnitine buildup, you see that there is no difference on the left-hand side panel in response to C4 acylcarnitine accumulation. The blue and orange curve are really overlaid, no difference whatsoever. However, if you look at C4 hydroxyacylcarnitine, which has been shown by other teams to be a biomarker of ketone usage in the muscle, we do see that BHB is triggering the utilization of ketones in the muscle with the nice buildup of C4 hydroxyacylcarnitine, while this is not the case in the maltodextrin receiving individual. So we think we have identified an interesting biomarker of BHB use in skeletal muscle. We still don't know really the biology beyond C4 hydroxyacylcarnitine, and so far it has been a curiosity on the MSMS spectrum, but it seems to be respond very well to exogenous BHB supplementation. When you look at, and this is interesting piece of data, this is free fatty acid elevation, and apologize, the colors are inverted here. So maltodextrin is in blue and DBHB is orange. I just wanted you to see whether you are following the presentation. You see that when you trigger exercise in blue here, in the maltodextrin receiving patients, you see elevation of free fatty acid. That's the typical treadmill response you would see, but it's not the case with BHB. And a number of teams have shown in different type of condition, including insulin resistance, that BHB infusion or oral administration is able to suppress lipolysis, likely or mainly via HCAR2 inhibition in adipocytes. So this seems to confirm in the context of FAOD, and this is likely the explanation why, by suppressing lipolysis, we are not able to see a buildup of long-chain acylcarnitine. When we look at functional parameters, heart rate, we didn't see any difference at baseline, obviously, and during the treadmill exercise. And again, this is a very moderate treadmill exercise. On the exertion score, the BOG score, no difference between baseline and the peak. And regarding CK level, even though they were very elevated already at baseline, those are normalized data. We didn't see much happening significantly on this small sample size on CK level, which is, after one single dose, would have been a major surprise to us, but that was not the case, and that would be investigated in more chronic setting. When we look at the tolerability in response to the product was well tolerated. You see on this VAS score and the GI scale here, from 0 to 10, all the data are between 0 and 1. We're pretty happy with that, and that's very consistent with some of the nutrition trial we conducted in other conditions, and not in patients, but in other conditions. We did see a bit of nausea and GI reflux, which is consistent with the DBHB tolerability profile, but was far better than what was reported in the same population with the keto ester as reported by the Dutch group 2 years back. So we didn't see no emesis at all. We didn't see any change in electrolytes in blood despite the increase in calcium, sodium, and magnesium, suggesting that after acute administration, safety tolerability profile was good. So beyond this acute dosing, we have also accumulated a large number of data supporting the chronic use of BHB for the management of FAOD. And this is a cartoon that summarizes the data we have from case studies. So obviously you have to be very cautious when you're reporting case studies, but it informs you on the safety, tolerability, and provide maybe sometimes some signal of efficacy, providing the rationale to go further into clinical trials. And you see in blue are depicted the key genes which are mutated for which the BHB has been tested. There's also some gray that you see on the right-hand side. Those are beyond FAOD, but those are key genes involved in the biochemistry of energy metabolism. And you see when you have a green tick, it means that it means that BHB, either as DBHB salt, either as keto ester, either as a racemate, has been successfully tested. So we and others have generated this data. We are fortunate to rely on a very dedicated network of investigators in the UK, where we are able to assess this, especially in the pediatric space, where the unmet need is the the biggest, obviously, and we have spectacular data. There's also some report coming from Australia and very few from the US, of course. So I think that altogether, these data strongly support the use or the rationale to use the DBHB for the management of fatty oxidation disorders. So to make a long story short, and I'm going towards the end of the presentation, the result from our in vitro study, actual clinical study, and case reports suppose we think, or we believe, or the use of ketone salts for the management of FAOD. Sorry, somebody's ringing me. And what are the mechanisms of action beyond this? Well, we know that DBHB is an energy source and an alternative fuel source bypassing the genetic defects in key tissues with high energy demands, such as the heart, for instance. We know that, and it's verified. I didn't show here, but we have also some preclinical data in mice models and more to come, suggesting that this is one of the key mechanisms involving the beneficial properties of BHB supplementation. We do also strongly believe that there's a key impact of the signaling properties of BHB engaging various signaling pathways such as lipolysis, inflammasome, but also and others, antioxidation, for instance. Where are we now within Nestlé Health Science, where we have developed a new salt formulation to improve long-term safety and compliance while maximizing PK, and it's within the regulatory toxicology program at the moment as we speak. And this project is aiming at entering clinical studies in patients in early 2026, not acutely, but more in a chronic setting, and defining the right dose to do long-term outcome studies. I'll finish here by acknowledging my collaborators, obviously the support of Bernard, that has been a true initiator of that program and been around in the ketone and a collaborator of you guys in Sherbrooke. Support of Chris Hendricks, a major figure in the rare disease community. In vitro work was completed with Steve and Joy within the team. And obviously a massive kudos to our collaborators in Oregon, Melanie Gillingham, Ashley, the student working on this project, and Carrie Hardy on the genetics. And I'll stop there and I'll take any question. Thank you.